excited to be here. Today we're going to be predicting the future, looking at tumor and patient characteristics that can be prognostic. We've talked about several of these in our sessions already, and today we're going to be talking about the fluid fundal cap and if it's associated with better hearing outcomes. So talking about the fluid fundal cap, when is it and what is it? And you can see on the right hand slide we have a small tumor with no fluid fundal cap. You see in the center slide we have a similar sized tumor that has a fluid fundal cap, and if you look at on the left side, you can have large or giant tumors that even still have a fluid fundal cap. And so what we wanted to study, and what the thought of this study is, well, if you have a fluid fundal cap, the longer it is, you're pulling that radiation dose away from the inner ear, away from the cochlea and away from the labyrinth. So we thought, and the hypothesis kind of was, well, if we're moving that dose away from inner ear structures, maybe the hearing preservation would be better. So we studied this with heavily weighted T2 sequences, usually the Kiss or Fiesta, and we measured from the fundus to the lateralmost part of the tumor. This was a retrospective chart review on over 100 patients. We looked over our 10-year period at our institution. We do 12.5 or 13 gray to the 50% isodose line, and then we use a Lexell gamma knife model 4C. Post-op following with the hearing was at 1 month, 6 months, and then yearly thereafter. And of course, not all patients complied. So looking at the hearing, of course, we looked at the hearing with the AO, HNS classifications, with the ABCD, but we wanted a continuous data to look at. And we did that with PTA changes. And so what we did is we said, well, if the PTA pre-treatment, post-treatment, so if the PTA shifted less than 20 decibels, then we considered that hearing to be preserved. If you had a 20 decibel or greater shift in the PTA, then that hearing was not preserved. And that's what we were looking at. With our 106 patients, the fluid cap was found in almost half the patients. As you can see, the length of the fundal cap did vary greatly, and there was no baseline characteristic differences. We had a nice spread of patients between these different categories, with a mean follow-up of about 5 years. Now we get to see our scattergram. Looking at the left side, we have our pre-gamma knife scores. In the center side, you see the post scores. And then my favorite diagram is that violin plot on the right. And if you look closely, you can see that right here, because the classification for ABCD are these hard cutoff lines that we all know, you see this one patient was at the very top of Class B hearing, and then after radiosurgery, she actually transitioned to Class A hearing. And this is why we also wanted to look at continuous data. So here is the meat and potatoes of this study. And so we looked at, on the left side here, this is with the ABCD classification. And then on the right side here is our continuous data. So let's focus on the left side first. This Kaplan-Meier survival curve looks at all patients with Class A hearing and if they had maintained serviceable hearing, their Class A or B hearing after gamma knife treatment. And you can see with the fundal cap, without the fundal cap, and you can see that there was no difference in the hearing outcomes with these patients with or without the fluid fundal cap. Now we looked at all patients with serviceable hearing and said, well, did the fundal cap make a difference in that setting? And you can see there's no difference. There's actually a trend for the fundal cap to be worse, but I really don't like when people say that. But it did not reach statistical significance, so there was no difference between these groups. Now looking at our continuous data, so if you had started with Class A hearing, did the fundal cap make any difference in preserving serviceable hearing, which we said was less than a 20 dB shift in the hearing after gamma knife? And you can see looking at Class A patients and then all patients with serviceable hearing, there was no difference in hearing preservation with having a fluid fundal cap or not. The one place we did see a difference was when we used our largest sample size looking at all patients with less than 90 dB PTA. Well, there's certainly several issues with this, which we will talk about. But I think the take-home message was, and this is, several discussions with our neurosurgeon, Jeff Japin, is regardless of the fluid fundal cap, that labyrinthine artery really is at or near the hot spot. And we think this is probably why, even though you're pulling the radiation dose more medial, you're still hitting the blood supply. And this is probably our best guess onto why the hearing is lost. The PTA less than 90 certainly was the largest sample size. Certainly if you had a PTA of 80, being able to see a 20 dB shift in the PTA is probably not a great way to look at this data, but we did want to look at it just because it was our largest sample size. So what are the take-home messages here? We found that a fluid fundal cap was not associated with improved hearing rates when you studied patients with Class A hearing or with Class A/B serviceable hearing, and really the only place we did find a difference was in that largest group, which of course has several different issues. We did look at a smaller group and say, different lengths of fluid fundal cap. We really worked this data to see if there was any difference, and we did not find any.